Again, those PDSA cycles, the Plan, Do, Study, Act, is key part to what the teams learn how to do and then are supported to do in action periods with the help of their practice facilitators. The learning model, again, I mentioned it was the IHI Breakthrough Series model that we're replicating in the work with as part of the QUIP Learning Collaboratives. And I won't go through that in detail. You've got the slide. But it really tracks on a very specific methodology that spans about 15 months. And teams are participating both in learning sessions where they come together as a group to learn together, and then go back and do what we call action periods where they are testing changes, reporting and measuring in their own practices, and then sharing that information with a whole group of teams that are part of this. So the QUIP Learning Collaboratives, very specifically, just so you know kind of what's entailed, if you are energized and excited and think you'd like to get in on this, we have an application process. We're just wrapping up our application process for our second learning collaborative. So teams have to think about whether they want to do this work, find out what's entailed, and then they form a QI team. So it's just a team from within the practice. It's not everybody from the family health team that comes. They identify a practice site with a physician and other key staff that want to do this work, and that's the QI team that comes and participates. Once they're in, we ask them to engage in what we call pre-work, which is really preparing to do the work. They have a package of information with a charter and information in it. And through that, they really start to get ready to do the work and think about how they can most effectively participate. So they need to look at the composition of the people that they are sending. Do they have the right people? And who's going to do what on that team? Because there's reporting, there's a need for lots of communication and keeping the team moving forward and organizing team meetings. So we ask them to think about that and start to meet as a team before they even come. They receive a charter for review and are asked to develop an aim statement that really is their overarching kind of guide to what they hope to accomplish through doing this work. And they also look at where they're at in delivering chronic illness care. And there's a survey that's part of the work that Mike did with Ed Wagner's group called we call it the ACIC, but it just gives teams again a sense of where do you think you are in these dimensions of chronic illness care, and it's kind of a baseline for them to get started. We also ask them to look at the baseline data, see what they can get out of their system so that they can get started in thinking of how they will report on a common set of measures that are part of the collaborative. Once they're in, they're attending 3 two-day learning sessions and a congress that track over a 15-month period. And in between that, as I mentioned, they're doing action periods of rapid cycle testing or PDSAs, and we hope that they're doing lots and lots and lots of those in between time. If they're only doing a couple, they're not getting it, and we've got a practice facilitator that's out there reminding them how to get back on track. They use the chronic care model really to drive change. It's really the thing that gives them the ideas of places where they can make change in practice. And it tracks on those 6 components that are in the model: the self-management, delivery system design, how they can optimize their care team, improve flow, decision support, again, how those clinical guidelines are really being implemented in practice and how can they make that more accessible at the point of care, looking at their clinical information system and how it can be utilized, certainly looking at community partnerships and how they use the resources that there exist in their community to get to that whole planned care model that we've been talking about. And then also there's a component that looks at the organization of healthcare, the system piece, and really that is about what's your broader environment for improvement. They are asked to report monthly on a common set of measures for diabetes, colorectal cancer screening, and access and efficiency. And that's coming. That's a switch for many people to be reporting on a monthly basis, but it's incredibly powerful because that's where you see how you're actually making a difference for the things that you're doing in the practice. And once you see those charts start to go up, and the kind of the Tabor one that Eileen shared, again, we're only 3 months in, so we're just seeing early stages of the graph going up, but we know that over time we expect to see a lot of exciting movement and on those graphs based on the work that teams are doing. We have a virtual mechanism for teams to connect through posting and sharing. Again, a bit of a learning curve there, but because we have teams from across the province, it's key that we have a mechanism for them to exchange and network between meetings so that they're sharing what they're doing with one another, because there's incredible power in teams being able to learn from one another, and that's a key part of this learning methodology. Just a final slide about the practice facilitators, the people that are working in the field with teams. We have 16 hired and trained to date. They bring skills and processes and content that really help support the QI work. And they support teams through a variety of mechanisms, both site visits, lots of telephone and email support. And we have team calls, teleconferences, conference calls, and the opportunity to always bring in our faculty. Mike and Eileen are both working with us on the collaboratives, and so if we get stuck with questions from the field, the practice facilitators always have another resource that they can go to get assistance to help teams move forward and answer their questions. There is an ongoing role, but obviously as teams mature and learn to do this work, that role would decrease. 3 collaboratives are being offered through QUIP from 2008 to 2010. We've, just as I mentioned, launched our second one, and we'll be offering a third collaborative that will start in March of 2009. There's an opportunity to send a team offered to all FITs in the province, and we have had an opportunity through a request from the ministry to offer slots to CHCs in the province. We have 5 slots held for CHCs in all 3 collaboratives, and again, we've had 2 participate in the first collaborative. Looks like there will be 3 in the second collaborative, and we hope that we will have 5 participating in our last collaborative. So it's been great to have another model of primary healthcare doing this work, lots of shared opportunity to learn from one another, and I think the CHCs have a bit of a leg up because they've got the team piece pretty well figured out, so their ability to accelerate some of the change, we're seeing that with the teams that are participating. We also have something called a shared care pilot initiative. I don't know if anybody in the audience is part of that funding model, but we also have an opportunity to involve a shared care pilot initiative in each of the collaboratives as well. And again, has brought a different model of primary health care to the collaboratives to learn about this work, and certainly has enriched the experience for them and I think for the other participants. So I am going to show you the video that hopefully rolls all together everything that I've told you into a 8-minute kind of presentation, and then we'll have questions. Thanks, everyone.